A question that we often need to ask is, when do we stop doing therapy? Unfortunately, in reality, sometimes we stop not for the right reasons. We stop because A, the patient ran out of benefits. A, B, you don't have time anymore. The healthcare agency, ceased paying. The patient's not well. I'm not talking about any of those realities, and I'm not denying that they exist. And sometimes we need to fight them. We need to be able to deal with it and to say, no, I'm sorry, that's really wrong. This is not what in the best interest of the patient. What I'm asking here is, when do we stop when we could continue? In other words, no one's telling us we have to stop. How do we know when to stop? We don't do therapy forever. We never do, not with any client. But with some clients, and some disorders at least, we stop when we're finished. In other words, a child has a distorted S sound. When it's no longer distorted, we know that's when we stop. There's no reason to continue. But our aphasic patient is never not going to be aphasic. They're going to be less aphasic, we hope. But when do we stop? When do we say, this is as far as it goes? This is the best we can do? Well, there are a number of ways of approaching it. I don't have a magic answer for you. But there are things that we need to think about. Okay. First off, aphasia therapy, aphasia recovery is very slow. It's never quick. It's quicker at the beginning than it is later on. That we know for a fact, and the patient will kind of spike a little bit at the beginning. You may show real differences between certainly week 1 and the end of the first month or the end of the second month. But certainly when we're looking further down the road, the difference between the second month and then the 2.5 month, or 2.5 and the third, those differences are minimal. Hopefully they're all pointing in the right direction, but it's really slow. It's slow. And that makes it a little bit more difficult. It makes it critical, though, that we keep meaningful data, because it can't be based on, well, kind of like, I think he's doing better. You're going to have to do a whole lot better than that. You're going to have meaningful data that indicate that this patient is better today than he was last week, or he's not better than he was last week. We kind of think about a plateau, okay? So if we take a look, and what we'll see is that a typical recovery pattern of a patient who had a stroke might be something like, you start on the left side, and we'll see that they're kind of flat at the beginning, and then they start to make rapid, spontaneous progress, okay? Spontaneous meaning even without us. They're going to start to make some progress. That's just natural recovery. Brain repairs itself to a degree. And as long as that's happening, and I'm not saying we shouldn't be doing therapy during that period, because we have good data that will enhance that, but that's going to stop. And that's when really the hard work begins. I think Marshall mentioned that last week. Okay, that's when the hard work begins, right around here. And here's when we start to do therapy, or our therapy becomes independent of spontaneous recovery. And what we're hoping to see is this kind of elevation, this kind of rise in abilities, okay? And we may have some dips. Not every day is going to be better than the day before. That's true for all of us, for everything. It would be nice to think that we're all linear that way, but we're not. We're human. But at some point, we're going to see that we get to a plateau. And the plateau is just simply defined as it's flat, where today is not any different from next week, and tomorrow is not any different from last week. We're just not seeing any change at that point. Is that when we stop? Well, maybe. Certainly we can justify stopping at that point. We can justify by saying that, you know what, we're not getting anywhere. We're not benefiting the patient. We're charging them, we're taking up their time, we're giving them hope, but in fact, nothing is really happening. We could do a little bit better than that, though, sometimes. And that is, sometimes when we sense, and we have data to indicate that there's a plateau, and a plateau, again, I'm not going to give you numbers because it wouldn't be fair. I would be afraid that you would take me literally. And I would say, a plateau for 2 weeks, or a plateau for a week, or a plateau for a month. It all depends. It depends on so many things. It depends on how severe the patient is. It depends on how much progress he's made. It depends where along the recovery he is. Are we talking in the 2nd month? Are we talking in the 6th month or the 2nd year? But at some level, we've reached what we think is a meaningful plateau. Often that's the time, and this is what I strongly recommend, and I'm not alone in this, that's the time we start to think about what can we do differently, okay? Because we have to assume, and I think it's only fair to the patient to assume this, the reason the patient hit a plateau is partially because they did, but partially it's because our therapy hit a plateau. And what we need to do is rethink our therapy. We need to think about maybe not even so much recovery as compensation. How do we get this patient to communicate better, even if his innate abilities are not better? But can we come up with techniques? Can we come up with strategies? Perhaps, and again, the natural instinct, the natural practice, I think, for most of us, is when a patient benefits less, we provide less therapy. I can justify 3, 4, 5 times a week if a patient's really making recovery. When he stops making such dramatic recovery, we kind of gear back and say, well, listen, can we really justify that kind of intensity when in fact they're not benefiting? I can make a counter-argument. My counter-argument would be, it's when they reach a plateau that I have to double down. It's when I know I have to make even more effort. Now they need even more therapy, longer sessions, more focused sessions, different strategies, because we're working through tougher situations. And in fact, what this drawing is showing us is that perhaps with focus, more effortful progress, more focused therapy, we actually can change that plateau and see a rise in behaviors. There's no magic to this. There's no, I wish there would be an exact formula that could apply to all patients. There's no formula that we can apply to any patients, frankly. Part of it is still gut. Part of it is based on our experience. Part of it is our sense of the patient and the patient's willingness to work through plateau. But again, just as I guess the underlying message that I want to get through here is that when a patient stops making progress, that doesn't automatically mean we stop doing therapy. That means we think that through and we start to come up with different strategies, different effort levels, and start to think about different techniques that might and hopefully will benefit the patient. Okay, deep breath. We're now going to talk about what I think in some ways may perhaps be the most important lecture we're going to have this semester in helping us understand aphasia therapy and how what we do helps and how do we structure what we do in order to help. It's based on a psychological model called the resource allocation model. Brookshire talks about it in our textbook. There's 3 or 4 full pages describing this. I don't remember the page number right now, but I'm sure you've read it, and if not, you will read it because it'll reinforce what we're saying here. I didn't make this up. I took this from our textbook. I'm just structuring it a little bit differently so that we can understand it better and apply it to our patients. Okay. So again, it's called the resource allocation model, and the subtitle is adjusting treatment tasks to the patient. Again, we come back to this notion that aphasia therapy is individualized. There is no such thing as valid or good aphasia therapy that is canned. that it's just kind of, you take it out of a book and you give the patient, okay, here's your workbook, go do it, come back and we'll check and see how you're doing. No. Every patient's different. Every patient's different every day from the way they were yesterday. Every patient's different from each other. And we're going to see that we have to totally individualize and adjust our treatment tasks to that particular patient and to their abilities. And what we're going to do now for the rest of this class is describe exactly what this resource allocation model is and how it helps us in terms of programming therapy for our patients. The first thing we have to, we know this, but we have to always keep in mind is that aphasics are also brain damaged. And so beyond the fact that they're linguistically and communicatively impaired, they have other problems. They have other issues that have to do with brain intactness. There are cognitive issues. There are memory issues. There are processing issues. All kinds of other things going on that possibly, according to many, as we've talked about before, that's what underlies the communication problems. But even if they're not, even if they don't define the communication problem, they're there. Nobody denies that. Nobody thinks that a person with aphasia has only a language problem. That would be naive. They have much more than that. What this model tells us is that if a clinician knows why the patient is having trouble, why they're having difficulty with communication, then we understand much better how we can treat that patient. How do we facilitate the environment so that communication becomes more available and more intact? Okay, so we're going to begin this whole trek, and this is going to take us some time to understand of what this resource allocation model is. And we're going to begin with a definition. And it states that every human has a finite amount of cognitive resources available for carrying out mental operations. Okay. Now, remember, this is a model. It's a model, which means we're not talking about a brain and how much nerve energy or metabolism of. It's none of those. It's a model. Okay, it's just a model, but we tend to think about the models that way anyway. What does the brain do? What does a person do? He carries out mental operations. That's what we all do. Okay. In order to do that, we need resources. We need fuel. What kind of resources? Well, we need cognitive resources because that's what the business of the brain is cognition. Okay. What kind of operations do we do? Well, we perceive stimuli, don't we? We perceive something that we see, something that we hear, something that we touch. We first perceive it. We just know that it exists. And that's way before we actually do anything with it. We just have to perceive that it's there. We have to see that there's some visual stimulus or an auditory stimulus. Way before we actually comprehend it, way before we store it, and way before we respond to it. Okay? All of these things are part of the normal communication process, and that is we have to perceive and we have to comprehend and we have to store and we have to respond. These mental operations in our model we'll refer to as cognitive processes, and the energy that we need in order to engage in cognitive processing are called processing resources, and we store those in a central pool. Because, again, if we think about this, so someone says something to you, and you now have to interpret that and respond. Well, let's think about the steps involved. The first thing is I have to hear it. I have to actually perceive that it's there. And then I have to interpret it. And then I have to store it. Just an immediate memory, a very quick short-term memory, so that I can process it and think about it and interpret it and understand it. And then I'm going to start the whole thing on the expressive side, which I'm not going to go into right now, and that's so I can respond. Well, in order to do all those different mental operations or these cognitive processes, I need resources. Well, where do I get these resources from? Well, they're endemic in me. I have them. I store them. They're in a central pool. Okay, they're in my savings account. Okay, I call upon them when I need them, so I can use them, but I keep them. They're in a central pool. Okay, we're going to stop. We'll pick up next